Welcome to part 2 of chapter 19. We're going to talk a little bit about blood pressure and we're going to talk about the regulation of blood pressure. Okay, first let's talk about maintaining blood pressure. This is all supervised by the brain, and here are several organs that have to work in cooperation to maintain your blood pressure. When they talk about blood volume, hopefully you're thinking about increased water. Maybe how do we do that? Kidneys, right? So they're trying to relate kidneys to this first item, blood volume. So if you increase water reabsorption in your kidneys, that would increase blood volume. That could increase blood flow. Remember, blood flow is the same pretty much as cardiac output, and then that would cause an increase in blood pressure. And then a decrease, if you decrease water absorption, all of those would go down. So the cardiac output here, if you remember, cardiac output is equal to heart rate times stroke volume. So here's where the heart comes in. If you increase your heart rate, you increase your cardiac output. And if you increase your cardiac output, you can increase your blood pressure. Now, when they talk about resistance, this is when they're talking about blood vessels. So remember that blood vessels can constrict or blood vessels can dilate. So vasoconstriction and vasodilation. So resistance can have an effect on your overall blood pressure. With this slide, basically, I'm just setting the stage for what we're going to talk about. So there's two short-term regulatory controls. One of them is neural, one of them is hormonal. And then we have long-term regulation. So this is renal controls. And when I say renal, hopefully you're thinking kidneys. Okay, let's talk about the first short-term regulation, and it's neural. So we're talking here about sympathetic neurons. Hopefully we remember, let me get it out, fight or flight. So remember, with fight or flight, we're increasing our heart rate, we're increasing our blood pressure, right? Getting excited, trying to flee, the bear's chasing you in the woods, right? So we can also change blood vessel diameter by that neuron firing. So that neuron can fire, it can go to the smooth muscle of the blood vessel. You remember the tunica media has this smooth muscle. And we can cause vasoconstriction or we can cause vasodilation. The neural controls that we're going to talk a little bit more in detail about are baroreceptors and chemoreceptors. Okay, let's talk a little bit more about baroreceptors. How are they initiated and what causes them? So they're reflexes, so they're going to be quick and they're going to be stereotyped responses. So baroreceptors are located in the carotid, the aortic arch, in the neck, and the thorax. So if you have increased blood pressure, it's going to stimulate a baroreceptor to increase the input into something called the vasomotor center. The inhibition of the vasomotor center will cause arterial dilation and venular dilation. So what we're saying is, if your blood pressure is too high, we can stimulate your vaso center, and that vaso center can cause dilation. So if your blood pressure is high and I dilate the vessel, right, the pressure on the vessel wall declines because you dilated. So then what happens to your blood pressure? It goes down. Okay, so here's a figure from chapter 19. Make sure that you can look at this figure and you can walk through the figure and explain it. Try to avoid memorizing just the blue bullet points. So here we have increased blood pressure. So if you have increased blood pressure, what happens? It triggers the baroreceptors. The baroreceptors send messages to the brain, and the brain has one of two pathways. It can do both at the same time, or it can do one or the other. So first, if you decrease impulses, so if you want to say inhibit impulses to the heart, and that's going to cause decreased heart rate. So if I have decreased heart rate, that should cause decreased cardiac output, which is the same as blood flow, so that should cause decreased blood pressure. So your blood pressure should go down. Second pathway. So it could inhibit the vasomotor area. And this would cause vasodilation. You can see the arrows making the vessel larger. If you have vasodilation, it'll cause decreased resistance, which will cause decreased cardiac output, which will cause decreased blood pressure. If some of you are questioning this right now because of what was in a previous slide, I think I mentioned before that resistance is, so I said if resistance goes up, then your blood flow goes down. I'm sorry, not blood flow. Oh, let's change the color. So if you have increased resistance, you have decreased blood flow. Well, that doesn't make sense here. Why are they both going the same way? So this is only true if you don't change vessel size. So in this case, if you vasodilate, you're giving the blood more room to flow. So that will decrease blood flow, and that will decrease blood pressure. Okay, so now we have the opposite. What happens if we have decreased blood pressure? If we have decreased blood pressure pushing on the wall of the aortic arch or carotid artery, that's going to stimulate the baroreceptors. They're going to send a message to the brain, and the brain is going to cause one of two or both actions to happen. So what happens if we stimulate the heart? If we increase sympathetic impulses to the heart, increase heart rate. If I increase heart rate, it's going to cause an increase in cardiac output, which is the same as blood flow, which is then going to cause an increase in blood pressure. So what's the second pathway? The second pathway is vasoconstriction. So we stimulate vasoconstriction in the blood vessel, and that causes increased resistance. You're making it harder for the blood to flow. So if you increase resistance, you're going to increase blood flow, and that's going to increase blood pressure. And so we get the same output here. I briefly mentioned chemoreceptors, but we're really going to come back and talk about this in chapter 22 when we do respiratory. I just wanted you to realize that there are some areas of the brain that can be stimulated based strictly on carbon dioxide or oxygen levels. So they will cause an increase in cardiac output, vasoconstriction, and we can increase the blood pressure. If our blood is moving faster, we'll push more CO2 to our lungs and we'll exhale. But I really want to wait till 22 to talk about it, but it should make sense to you that if your carbon dioxide levels are high, that we need to do something about it, right? If they're high, we want to exhale more. And how do we get ourselves to exhale more? Well, if I increased my blood flow and my blood pressure, I could be pushing more blood to my lungs and getting rid of the carbon dioxide and picking up oxygen. All right, here's the other category. They're just letting you know that the higher brain centers can also have an effect on blood pressure. And you can see right here, if you're under a lot of stress, your hypothalamus can increase your blood pressure. So if you've ever met somebody and you're nervous, right, you know who you're meeting, that's your cerebral cortex is engaged, and that's what's causing the anxiety. Also, your hypothalamus, we'll see in a later slide, can redistribute blood flow during exercise. So there's a nice figure coming up. We'll see that in just a second. I told you they'd come back, right? Hormonal controls. This is our endocrine. So what can hormones do? They can regulate your blood pressure. They can have short-term changes, meaning this is peripheral resistance. If you see resistance, you should automatically be thinking about vasoconstriction and vasodilation. And then we have long-term changes in blood volume. So you should automatically be thinking about, if I increase my water, eventually blood flow, eventually blood pressure, right? So let's look at a couple of these. We have our adrenal medulla hormones. We have epinephrine and norepinephrine. They can cause an increase in cardiac output and vasoconstriction. So why? How? So what do these guys do? They increase heart rate. If I increase heart rate, what else am I going to increase? Cardiac output. If I increase cardiac output, that's the same as increasing blood flow. If I increase blood flow, I increase blood pressure. So you need to be able to explain this and how epinephrine and norepinephrine increase cardiac output. Vasoconstriction is pretty simple, right? We notice if you have vasoconstriction, you increase resistance. If you increase resistance through blood vessel change, you'll increase cardiac output. And if you increase cardiac output, increase blood flow. I feel like I'm saying the same thing over and over again, right? All right, angiotensin 2. So I have a slide coming up, it'll show you, but hopefully you remember renin, and that triggers angiotensin 2. It causes water retention and vasoconstriction. So if we have increased water, that's going to cause increased blood flow, blood volume, blood flow, and then eventually blood pressure. Remember ADH, water retention, vasoconstriction. So all three of these are going to cause an increase in blood pressure. And then remember, we have this one atrial natriuretic peptide that causes a decrease in blood pressure. So decreases blood pressure by antagonizing, shutting off aldosterone. If you shut off aldosterone, no more reabsorption of water. So no more reabsorption of water is going to cause your blood flow to go down and cause your blood pressure to go down. If you didn't remember the renin, angiotensin, or you wanted to come back and look at atrial natriuretic peptide, this is a good figure back in chapter 16 to go review. This is also a nice figure in 19 if you're more of a visual person and you want to see what is the stimulus, what is the response, and then down here, what is the result. So you can follow these pathways. So what happens if you have a loss of fluid from hemorrhaging or excessive sweating? You're going to have decreased blood volume, decreased blood pressure. What are we going to trigger? Baroreceptors, activation of vasomotor cardiac. So you're going to increase heart rate. You can also come down here and decrease the diameter of the blood vessel. All of that is going to cause an increase in blood pressure. So if you like this visual representation, go ahead and look at it. I don't have anything highlighted in red on this slide, but I think this is just a good overall summary. So why do we care so much about blood pressure? Well, you have to have blood pressure that's high enough to provide adequate tissue perfusion. They mean enough oxygen to your tissue, but not so high that the blood vessels are damaged. Again, I think we use kind of the fire hose analogy. If you have blood rushing to an organ or to tissue, if it's under too high pressure, it can destroy the tissue and the cells. So the example here, if your blood pressure to the brain is too low, basically your tissue's not getting enough oxygen and nutrients, and the person's going to lose consciousness. If the blood pressure in the brain is too high, the person could have a stroke. So if we're going to monitor, and they say circulatory, again, remember that we haven't talked about lymphatics yet. So remember, circulatory is lymphatics and cardiovascular systems kind of lumped together. So if we're going to monitor kind of your circulatory efficiency, these are some of the vital signs that we take. We look at your pulse rate, we look at your blood pressure, your respiratory rate, your body temperature, right? So what is your pulse? We're just going through explaining these. Pressure wave caused by the expansion and recoil of the artery during cardiac cycle. So basically, as your heart is filling and contracting, that pulse that you feel is just the expansion as the high pressured blood moves through, and the recoil as you have a decrease in pressure after the blood has moved through. Here's some of the areas that are best suited to take a pulse that you can feel the throbbing of the artery. You'll see people a lot use the carotid, or they'll use the radial. Okay, so measuring blood pressure. These are kind of the steps you would walk through, this slide and the next. I'm not going to go through them. Instead, I'm going to post a video. So I'll post a video of someone taking someone else's blood pressure and kind of walking through the steps. How do we measure this, though? I wanted you to see that there's something called a sphygmomanometer. So this is not just the cuff part, this is the dial part where you're actually measuring the systolic and the diastolic pressure. So when we take blood pressure, we usually say top number over bottom number. So this is systolic over diastolic. You should be thinking of it as contraction force over relaxation force. Oh Lord, relaxation force. There we go. There are variations in blood pressure. It doesn't stay constant. It cycles over a 24-hour period of time. Your blood pressure usually peaks in the morning due to the fact that you have increased hormones. But here are some factors that we can look at that cause variations in blood pressure. So age, usually if you're over 40, so that kind of over 40 mark, usually you have increased hypertension. Sex is different between males and females. Weight, race, mood. Think about if you're stressed out. Also, your posture may vary your blood pressure. Usually when they're making you take blood pressure, you're sitting down, right, in a chair. If you're laying, if you remember this term from 201, supine, your blood pressure is a little bit lower. I think that's about the average. A little bit lower if you're laying down. So that would make a difference if you're taking hospital patient samples and they're laying down versus sitting up in a chair. Something they don't mention here also is diet. So diet can affect, if you have high amounts of sodium, that could affect your resting membrane potential, that could affect contractility, right? And that could affect blood pressure. Also, if you don't have enough calcium in your diet, some decreased calcium, decreased potassium, some of those things could cause issues. Let's talk about hypotension. So basically this is low blood pressure. This is systolic pressure below 90/60, often associated with long life, lack of cardiovascular illness, not really a concern unless you're getting inadequate blood flow to your tissues. So if your oxygen level is too low because your blood flow is too low, then that could cause tissue death. So as long as your tissue is getting adequate supply of oxygen, if you have a low blood pressure, it's not quite as bad. So sometimes we give specific names to the type of hypotension. So here's orthostatic, here's chronic, and here's acute. So orthostatic hypotension, temporarily low blood pressure and dizziness from sudden rising or reclining position. You'll often see this in elderly patients. So their neural controls aren't working as well. So you have declined neural function, and that affects those baroreceptors. I'm running out of space. Baroreceptors. And so you can't adjust your blood pressure as quickly as you get older. So that causes kind of this dizziness because your blood pressure drops too low. There's chronic hypertension. So this could be poor nutrition, this could be Addison's disease, hypothyroidism. All of these can cause decreased blood pressure. And then this acute hypotension, usually circulatory shock. So you have some sort of, bleed, you're bleeding, hemorrhage. So acute, and hopefully we know by now, acute means now. Usually we think of acute as kind of short term. And then chronic is all the time, daily. So this is some sort of long-term problem. So now we move to hypertension. So this is sustained, not just temporary elevated, but sustained blood pressure over 140/90. So it can be transient. So like during a fever, you could have elevated blood pressure. Physical exertion, when you're working out, you can have elevated blood pressure, or if you're upset or emotional. But blood pressure is usually persistent in obese people. Again, this could be diet related, or it could be genetic related. All right, so hypertension, why is it so bad? Because prolonged hypertension can cause heart failure, vascular disease, renal failure, and stroke. So if we're thinking stroke, we're usually thinking of blood supply to the brain. There's several risk factors here, right? Having diabetes, if it's hereditary, certain genes turned on or off. Diet, obesity, age, stress, smoking. Basically, if your heart is having to work harder, what happens to your myocardium? It can enlarge, it can become weak, it can become flabby. Do we remember that dilated cardial myopathy? If not, go back and look at the heart chapter. We talked about that. Also, it can accelerate plaque buildup. So remember, this is the plaque buildup. Clog your arteries. So if you're in circulatory shock, this is any condition in which your blood vessels are not filled adequately and you cannot circulate blood normally. So if you have decreased blood flow and decreased blood pressure, and that means you're not getting enough blood Not enough, sorry, that was supposed to be a 2. Not enough oxygen, your tissue becomes hypoxic, right? Hypoxia. And then this can lead to tissue death. So we have to have an adequate blood supply. All right, lots of information on this slide. Here's some other terms, right? Hypovolemic shock, so this would be low blood volume. That's what we're saying, right? From some sort of large-scale blood loss. If you have low blood volume, you have low blood flow. If you have low blood flow, you have low blood pressure. And then if the oxygen to your tissues is low, the perfusion, then you're going to have tissue death. All right, what about vascular shock? Extreme vasodilation, decreased peripheral resistance. So you can have vascular shock where you have extreme dilation here, and that's going to cause decreased blood flow, decreased blood pressure. Again, same pathway here. If you have decreased oxygen to your tissues, that can also result in cell death. So when does this occur? If you have allergies, if you have severe allergic reaction. So I don't really have a lot of room, but increased histamine can cause vasodilation. Also some bacteria, like if you have septicemia, bacteria can also cause vasodilation. Transient vascular shock, this is prolonged exposure to heat. So remember, what are we doing with our blood volume when we're hot? We're pushing it into our reservoir, which is our skin. And so we can have decreased blood volume, and we can have decreased blood flow, and we can have decreased blood pressure. And then they have something called cardiogenic shock. So this is if there's an inefficient heart pumping. So this could be because of myocardial infarctions, right? Heart attacks. Something is happening that the heart cannot sustain adequate circulation. Maybe you have a blocked artery, or you have some sort of heart attack and it's stopping the heart from pumping because the myocardium isn't able to get oxygen. Okay, now we're going to talk about control of blood flow. So we have the ability to adjust the rate of flow, so the right amount of blood to that tissue or organ. So we don't want the blood pressure too high, and we don't want the blood pressure too low. We want somewhere in that middle spot, right? So we can adjust the rate of flow of our blood. Also, these are always changing, right? If you're working out, you have high blood pressure. If you're getting ready to go to bed, you probably have lower blood pressure. So they use this term tissue perfusion, blood flow through the body tissues. So we're talking about delivering oxygen and nutrients like glucose, and then removing waste from our tissue. We're talking about gas exchange. Remember, at the lungs, we have to drop off CO2 and we have to pick up oxygen. In our digestive tract, we have to be able to absorb nutrients, and in the kidneys, we have to be able to form urine. All right, control of blood flow. We got short term and long term. So short term, we can do these two, extrinsic or intrinsic. So short term, sympathetic nervous system, right? If we increase heart rate and we increase blood pressure, then we can increase blood flow. We also have intrinsic controls. If you remember, we talked about the arteriole coming in. Oh, sorry, that was kind of bad. There we go. So this is the arteriole, and this is the venule, and this is the capillary bed. And we said that here in the arteriole, you can have sphincters. So this is a intrinsic control. Those sphincters can close, and then that would just allow the blood to flow through the middle portion, our meta-arteriole. So go back and look at that and see if that made sense, those sphincters. And then we have long-term. We have something called angiogenesis. This is common in the heart. Basically, it can increase the number of blood vessels, so increase blood vessel number, and we can also enlarge vessels. So sometimes if people have blockages in some of the smaller arteries that feed the heart, they can have another branch created off of a major artery, and that term is called angiogenesis. So we do have the ability to grow new blood vessels. The book goes into great detail about blood flow to each of these organs. If you'd like to read more in the book, please feel free. I just thought this was a nice figure to kind of sum up what's happening. So I just want you to look at the correlation between if you're at rest versus if you're doing some sort of strenuous exercise, right? So here we have the brain at about 750, then we're talking about the flow, so millimeters per minute. Maybe I should do green again. Milliliters per minute. So the blood flow to the brain stays about the same. Look at the heart. So if you're working out, that's about 3 times. Skeletal muscles, that's about 10 times as much blood flow, right? Skin, remember we push blood out, that's about 4 times. What happens to our kidneys? Kidneys decrease blood flow. We do not want to have to stop and urinate if we're working out. What about your abdominal area where you do all your digestion? Decreased blood flow. So they just want you to show that your blood flow has different rates in different organs depending on the activity. Okay, now to the fun part. We get to talk about hydrostatic pressure and osmotic pressure. So bulk fluid flow across a capillary wall causes continuous mixing of fluid between the plasma and the interstitial fluid and maintains the interstitial environment. So I just want to go back and make sure we understand the base. And I have a capillary bed coming up. I don't know why I feel the need to draw because I can't really draw. But this is your arterial side. This is your venule side. And here is my capillary bed. We remember that as oxygen is coming through in your blood, right? Blood's flowing through the capillary bed. The oxygen goes into this area, which is called interstitial fluid. And then, this is my, I'm going to say tissue, right? So then the oxygen gets picked up by the tissue. So you have to travel in this interstitial fluid space to go from the capillary bed into the tissue. Okay, so we're going to talk about these 2 items, hydrostatic pressure and osmotic pressure. So we're talking about fluid movement. Basically, what I'm trying to explain to you is how fluid moves through a capillary bed. And it all has to do with force or pressure. Okay, so what is hydrostatic pressure? It is the force exerted by the fluid pressing against the wall. So I've got my vessel here, and I've got fluid, and that fluid is pressing on the wall. That is my hydrostatic pressure. Osmotic pressure, the force exerted by proteins found in the blood plasma. So if you have a fluid here and it has proteins in it, those proteins, you can think of them as solutes, right? If you remember osmosis, we're saying wherever your solutes are high, you have water trying to come across the membrane to dilute out those solutes. That creates this osmotic pressure. So the force exerted by the proteins found in the blood plasma or in the interstitial fluid. Okay, here's our arterial, here's our venule, here's our capillary bed. Hopefully we know the blood flow, what's happening, right? We're going to have oxygen. It's hopefully going to go to interstitial fluid, hopefully get picked up by tissue. Then the tissue puts out carbon dioxide, and that gets picked up on the venule side of the capillary bed. Excuse me. What they're looking at is overall pressure differences. So they're saying the hydrostatic pressure pressing down from the capillary into the interstitial fluid is 35. The osmotic pressure caused by solutes, right, plasma proteins, the pressure pushing back is 25. So if I have 35 pressing down and I have 25 pushing back against, that leaves me with a difference of 10. But what way is the net movement? Down. So let me do that again. You have 35 pressing down, you have 25 pushing back. The difference between that is 10, and which number is greater? The pushing down, right? So the only reason that oxygen leaves the capillary bed, the only reason that oxygen leaves the capillary bed is because the force pressing out is higher than the force pushing back. On the venule side, we have the same force, right? Osmotic pressure pushing back, but now what's the force pressing down? It's only 17, but we still have 25 pushing back. So the 25 is greater, so this is the reason that CO2 gets picked up on the capillary side. So again, remember your pressure is 35 pressing down. Over here, it's 17 pressing down. The osmotic pressure stays about 25. So that's the pressure pushing back. So you can see that this is greater than the 25. So that's why we push oxygen into the interstitial fluid. And what's the reason that we pick up carbon dioxide? Well, here's 25. You have 25 pushing back into the capillary. You have 17 coming down. Well, the 25 is greater than the 17. So the carbon dioxide gets picked up on the venule side. So the whole point of this that you should be able to realize is that the only reason oxygen is pushed down and carbon dioxide is picked up in a capillary bed is based on pressure. So let's look at this again. We said we got 35, keep switching on me. We have 35 pressing down. We have 25 pressing back. That's a difference of 10. And the 35 is greater, so that's what causes oxygen to be pushed into the tissue. On this side, we still have 25 pressing back, but now we only have 17 pressing down. The 25 is greater, so we pick up the CO2 on the venule side. So real quick, think about this for a second. Why does blood pressure and circulation matter? So we said this force is 35 pressing down. This force is 17 pressing down, and we've got 25 pressing back, right? Okay, so what happens if you have high blood pressure? If your blood pressure, let's say instead of 35, what if your blood pressure was 40, I want to exaggerate it a little bit more. So let's say 55. If you have high blood pressure, as it makes its way through your systemic, by the time it gets to the capillary bed, it's going to be elevated, right? So instead of having a force of 35, let's say we have a force of 55 pressing down. So, we're like, oh, that's great. We'll just have more oxygen pushed into our tissue, right? Okay. If this number goes up, what do you think happens to this number? It goes up as well. Good. So this went up 20 points. Let's say this goes up 20 points, and now we're at 37. If we're at 37, what's the opposing pressure pushing back? It's still 25. So what's going to happen? If you have 25 pushing against 35, you're still going to have this downward pressure. Are you going to be able to pick up CO2? Not as easily, right? You could also argue that if your blood pressure was higher, so 55, you'd be pushing more oxygen, you'd be pushing more fluid, and then you could have fluid buildup here, and that could affect your osmotic pressure as well. But overall, if your blood pressure is high, it's going to mess up this system that we've designed, right? We're supposed to be at moderately low blood pressure in the capillary beds because we want to make sure oxygen goes out and we want to make sure carbon dioxide gets picked up. So you can think of it the other way. What if you have, I know I kind of just said this, edema, if you have swelling. So what if this osmotic pressure increases? So let's say we're still here. Let's say we have 35 on this side and we have 17 on this side, pressure-wise, right? So hydrostatic pressure. What if my osmotic pressure due to swelling, what if it goes up? What if my pressure here due to swelling, my osmotic pressure goes up to 40? So now this number is greater. So I'm trying to push oxygen in, and the force pressing against that is higher. So you're not going to have as much oxygen dropped off. So again, the whole reason that I'm trying to explain this hydrostatic and osmotic pressure is to let you know that we have a nice balanced system set up so that we drop off oxygen here and we pick up CO2 here. And if you change these pressure differences, it can affect the entire system. So we do not want high blood pressure because it would mess up the dynamics, the pressure dynamics for pushing oxygen into our tissues and for taking the CO2 and bringing it back into the capillary bed. Okay, there are some important differences that we need to look at between arteries and veins, and I color-coded it for you, so hopefully it would be easier. So number one, there is only one systemic artery, and it's called the aorta, but there are two systemic veins, superior inferior vena cava. So we have one aorta, but we have two vena cava. Arteries run deep, but veins are both deep and superficial. 3, arterial pathways tend to be clear. You're going to see as you're studying, aorta leads to subclavian, which then leads to axillary, which then leads to brachial. It's very clear to follow. Venous pathways are not. You're going to have multiple pathways. So you're going to have multiple vein pathways back to the heart. You have redundancy with veins. And then 4 here, there are some areas where venous drainage does not parallel the arterial supply. One of them is in the brain. We saw this when we looked at dural sinuses back in 201, but this is the one we really need to focus on, and we're going to come back and talk about it again with digestion. But the hepatic portal system drained from digestive organs to the liver before entering the main systemic circulation. So you're going to see the spleen, the intestines, and the stomach all drain into something called the hepatic portal vein. I think the book also calls it just portal. That's going to go to the liver, and your liver is going to clean it before it dumps it back into the inferior vena cava. So remember, all of this blood, if it's the spleen, it's worn out cells. It could be, remember we have lots of T cells and B cells in the spleen. Intestines, this is food that you're consuming. Stomach, food that you are trying to break down, right? So basically these are the areas where you'd have the most contaminated fluid, and so you want to clean it through the liver before you dump it back into the vena cava, because remember the vena cava goes straight to the heart. Okay, let's look at the arteries of the abdomen, and then we'll move on and talk again about hepatic. So here's my abdominal aorta. So this red tube is my abdominal aorta, and you're going to have branches off of it that feed all of the organs. Usually they're named pretty nicely, right? If you have a gastric artery, if it's an artery, it's going away from the heart. If it's systemic, we know that it's delivering oxygen, and it's probably red. So gastric artery, it's the red artery that's feeding the heart. Splenic artery, that's the artery that's feeding the spleen. Let's see, where's there another one? Hepatic artery, well, that's the artery that's feeding the liver, oxygenated blood, right? So there is this little hub. So let me erase that and just do a box here. There's the hub, and that's called the celiac trunk. So the celiac trunk, you can see it's going to feed the liver, it's going to feed the stomach, and it's going to feed the spleen. So off of the celiac trunk, you have branches that are going to go and feed all of these organs. Here's another nice figure from your book with the arteries of the abdomen. They've stripped all of the anterior organs away so you can see all the different branchings. So you can see here is my hub, my celiac trunk. Remember, that's going to feed the liver and the spleen and the stomach. And then you can see next you have adrenal arteries, right? So you can see them coming off and feeding the adrenal glands. And then here you're going to have a renal go into the kidneys. And then you're going to have superior mesenteric hub here. Then you're going to have gonads on either side. They're either going to go to the ovaries or the testes. Then you're going to have inferior mesenteric. That's another branch coming off. And then eventually we're going to split into our iliac arteries and go to our lower extremities. The mesenterics here, the superior and inferior mesenterics, we're going to group these together, and we're going to say these feed both small and large intestines. It's really hard to differentiate which one feeds which. There's a lot of overlap here. So we're just going to say both. So superior, inferior mesenteric arteries would supply blood to both the large and small intestine. Okay, here's a nice image of the veins, and they're trying to show you faint in the background the inferior vena cava. So if I was to turn this model to the side, you'd see this parallel kind of structure where you'd see the inferior vena cava running posterior, and then anterior you have the hepatic portal vein, and then you have the organs that are feeding into the hepatic portal, and I have them highlighted here. So here's the gastric vein. The gastric vein is going to feed into the portal. The splenic vein starts over here at the spleen, goes all the way, feeds into the hepatic portal, and then you have your mesenterics. They're going to feed as well into the hepatic portal. So these are the items, and you can group these together. You don't have to say superior, inferior. You can just kind of group them into mesenteric. If I asked you organs, you would say stomach, spleen, large and small intestines. Okay, so they all feed into the hepatic portal. And where does that hepatic portal go? It goes to your liver. And your liver is going to clean those fluids before they dump them back into the inferior vena cava. Okay, this is also a nice flow of information. They call it a schematic chart. You can see the inferior vena cava in the background, and you can see in the anterior side or foreground, you can see the hepatic portal. So here's hepatic portal. They're trying to show you the hepatic portal vein as it goes into the liver. So if we had to do kind of a flow chart on our own, hopefully we could do this. We'd say the stomach, the spleen, and the intestines. Let me get it out, right? Intestines, this is both large and small. All three of these are going to drain into the hepatic portal. The hepatic portal goes to the liver. The liver cleans the blood, and then the liver has hepatic veins, and those dump into the inferior vena cava. So sometimes this is hard for people because there's hepatic veins here and there's hepatic portal here. So I think of the hepatic portal as the dirty blood coming from the digestive organs, and maybe spleen, you don't want to call that digestive, but dirty blood nonetheless. Dirty blood goes into the liver, and when the blood comes out, it's clean blood. And that clean blood you would find in the hepatic veins as they dump back into the inferior vena cava. So you can see right here, the liver dumps back into the inferior vena cava by hepatic veins. So now we're looking at our inferior vena cava. So this whole section from here to here, this is all inferior vena cava. So we can see our iliacs are draining into our inferior vena cava. We can see our gonads are draining into our vena cava. The left gonad actually goes to the renal first before it goes back to the inferior vena cava. You can see your renal veins draining. You can see, let's see, where is it? Hepatic veins. Here we go. Here's the hepatic veins draining into the inferior vena cava. So remember on this, you should not see, so no spleen, no stomach, no gastric vein, right? No splenic vein, gastric vein, and mesenteric vein. Where do those drain? They all drain into the hepatic portal. So you're not going to see them going directly to the inferior vena cava. So to wrap up chapter 19, some of the developmental aspects, you can see there's something called vascular endothelial growth factor, and that's going to determine whether a vessel becomes an artery or vein. Your heart is going to pump blood by about week 4. We already talked about those fetal shunts. And then as with everything, as you age, you have problems with plaque buildup, varicose veins. You can have increased blood pressure. You could also have that orthostatic hypotension. You have issues going from a sitting position to a standing position. Basically, your neural controls don't work as well, so the baroreceptors don't work. So with age, everything declines, right? Well, I hope you enjoyed chapter 19, and I'll see you for chapter 20.